Hello, my friends. Welcome to the podcast. Today we have a special interview. I wanted to learn more about the clinical nurse specialist role. I think this is one we don't learn a whole lot about as early in the career options. And I know we're all very familiar with CRNA, nurse midwife, all the things. Let's learn a little bit about this phenomenal option of becoming a clinical nurse specialist, okay? Who better to tell us about clinical nurse specialists than the president of the National Association of Clinical Nurse Specialists? Sound like a good idea? I think that sounds like a safe place to gather this information. Okay. So I had the joy of interviewing Dr. Mitzi Saunders about this role. Phenomenal advice. I mean, this interview is gold. Okay. But let me tell you a little bit more about her educational clinical background so you have a little baseline understanding before we start the interview. Okay. Let's go through her bio together, shall we? All right. Dr. Saunders became a certified adult health clinical nurse specialist in 1994. In 2000, she took an academic leadership position at the University of Detroit Mercy and completed her PhD in nursing in 2006 from Wayne State University. No big deal. She's got a PhD. Her research focuses on 3 different areas: improving health outcomes in family caregivers of patients with heart failure or dementia, improving the delivery of online health education, and increasing the visibility of the CNS role to achieve full scope practice for all CNSs. Dr. Saunders has directed the Adult Gerontology CNS online program at Detroit Mercy since 2007, which, no big deal, boasts a 100% national certification pass rate. Overall, Dr. Saunders is a tenured professor, and she is actively leading an effort to support advanced practice nursing at the local, state, and national levels. She functioned as secretary for the Michigan CNS Association and participated in successes for Michigan CNSs to include title protection and prescriptive authority. And as I mentioned, she's currently the president of the National Association of Clinical Nurse Specialists. So I'm so grateful that she took the time to chat with us today. And so I hope you enjoy the interview. Well, thank you so much for joining us for the podcast today, Dr. Saunders, but who has so graciously given me permission to call her Dr. Mitzi. Thank you for being here today.
Of course. Thank you.
So I wanted to just jump into questions. So let's say my audience has no idea what a CNS is. Maybe they understand what an NP is, a nurse practitioner, but CNS, not sure what that is. Can you give us like a basic definition of what a CNS is and where you might see that individual clinically?
I sure can. So we'll start with a registered nurse. We're all very familiar with what a registered nurse does. So the next level of registered nurse puts 2 letters in front of RN, APRN, Advanced Practice Registered Nurse. And there are 4 types of advanced practice registered nurse, only 4. And every nursing organization has authorized these 4 in legislation, everything. It is either nurse practitioner, which you all know about. It is nurse, and it used to be anesthetist. Now it's nurse anesthesiologist because they've changed their name.
I didn't know
nurse
that.
Midwife, which you probably know of. Mm-hmm. And then there's the third one called clinical nurse specialist. Now we're the different one. And why a clinical nurse specialist is different is because we not only focus on advanced direct patient care within a specified population, but we also focus on the nurse as our patient. So we're an elbow consultant to the nurse. We are there at the front lines of care to support the nurse. And I can tell you, senior level executives across every healthcare system wishes there were enough CNSs to put on every unit of every acute care facility, because we know how desperately needed the support for the nurses right now. Okay. And then our third sphere, and if you could see my shirt right now, I have my NACNS shirt on, National Association of Clinical Nurse Specialists. It's my work shirt. there are three spheres because our patients are our population of patients that we specialize in, the nurses who care for that specialty population, and then the system. Because we know when we start working with the nurses and we start working with patients, we start to identify all kinds of gaps in the system. So we are also experts in changing the system. So a clinical nurse specialist not only gets all the skills and tools to be able to prescribe care, prescriptive authority, to do that for patients, to work one-on-one with the nurses as a clinical expert and role model, but we can also change the whole system. And we get the tools to assess a whole system as if you assess a patient and make a diagnosis. We assess the whole system and make a diagnosis. And then we put a whole plan in place and we assemble a team and we lead that team and we make changes in the system. So if you're a system who's having too many falls, patient falls, we are going to fully assess that problem, work with all the parties at play, which would be the nurses, the nursing assistants, everybody involved with patients. How can we reduce our falls down to an acceptable level? Right now, it's not supposed to be more than 3.6 every 1,000 days. So how do we get our numbers of falls down? Because we know every fall costs the hospital $65,000 that's not reimbursed. Mm-hmm. So a CNS thinks in those terms. The way I just said that to you, that's the way a CNS thinks. We're there in a population of patients. I was a medical surgical CNS, so I covered med surg. I wasn't in the intensive care. I wasn't in the ER. And most CNSs are in acute and critical care environments. So that may be why you know less of them, because nurse practitioners are out there everywhere, mm-hmm. mostly not in acute care. But mm-hmm. we're tucked in acute care dealing with complex problems.
So that was going to be my next thing, was we're so familiar with that NP role.
Yeah.
I'm hearing the biggest difference, like, with an NP, they're like, okay, if
minute clinic.
Yes. But they are in the hospital too. And working alongside PAs. So I'm wondering, the big difference is when you say you're in med surg, are mm-hmm. you in the med surg service line, as opposed to like the nurse practitioner who sees a med surg patient is with like internal medicine or with whomever, like you're under, like that NP is under almost that medical hierarchy or system, like with all the provider, like the physician. But what I'm hearing is you're separate of that.
Yeah, we tend to fall under nursing because we're working for the patients, the nurses, and the system. A nurse practitioner is seeing a patient one after another, right. 3 patients every hour. That's their role. And it's that one patient at a time kind of approach. So that is a big difference. The majority of nurse practitioners are 90% of them are not in the hospital. Mm-hmm. They truly are out in the community where they seriously, they see one patient after another. Right. So the nurse practitioner training is to do just that. And mm-hmm. it does look very medical, right? That's more of a medical model. And I would say for your listeners, if you're thinking, I want to be an APRN, mm-hmm. You have 4 choices. Maybe I don't want to see patient after patient. I'm a little fed up with what I see in healthcare. I want to make some change happen. I want to be a leader. I want to focus on the diabetes population or the ER population or the perioperative setting. I want to be a specialist in that area, but I want to really improve the way things are happening. I want to improve the environment for nurses, what they're working under. My students, I've just been listening to my CNS students' presentations. I had two of them do their presentations on workplace violence, because we know like workplace violence is increasing 20% year over year. Who's going to fix that? We can bring in more security. We can bring in more canines to de-escalate the situation. Nurse practitioners are seeing patients, physicians are seeing patients, PAs are seeing patients. Who is going to tackle these system problems? The clinical nurse specialist. So you see, we have so many issues out there. We just don't have enough clinical nurse specialists. And so We are at a shortage. And I spoke with an executive of a large chain. I won't mention the name, but about 150 hospitals across the country. They want a CNS in every unit. I mean, they literally, and how can we get more? They're asking me, we need them, you know? And I said, well, there's a nurse practitioner school on every block. So
Yes.
that's where people end up going. But we need a show like yours and other exposures out there to say, no, wait, there are a lot of clinical nurse specialist programs out there. A lot of them run fully online, and you can take them from other states and do your preceptors near your home, your preceptorships. And if you go to our NACNS website, we have a lovely CNS program directory that you can search through and compare different programs. We have 60 plus wonderful program directors across the country. I know about all of them. Call them, talk to them, and explore the CNS role. Because I think if more nurses knew about it, they'd do it.
So let's say someone is interested. What is maybe your bachelor's in your BSN program? What is the educational pathway? What is required? Like, for example, like we've talked about with nurse practitioners, you can get a master's, but we're kind of moving towards the people are preferring jobs or preferring people to have DNPs and things. So I'm curious, what does that educational pathway look like for the prospective CNS?
Yes. So, and I'm speaking as president of the National Association of Clinical Nurse Specialists. So we have an entry for practice statement, and exactly what you just talked about, Katie. We dove in really deep to look at the DNP, the master's level nurse, and we looked at all the competencies of the clinical nurse specialist. And we did this huge crosswalk analysis of all the competencies of the graduate level DNP with the CNS. The DNP is a systems level leadership degree. Okay, it's not a role, it's a degree. When we cross compared what the CNS is, we found out that the DNP, many of those competencies are foundational to the CNS role. Okay. So we came out very strong, and the statement is on our website, that you can practice as a CNS at the master's level. You can get a DNP, that's totally fine, but so most of our CNS programs are at the master's level, okay, and you can graduate with that and be your APRN CNS, no problem. If you already have a master's degree, come back to one of our postgraduate certificate programs and finish it in a year. So you do not have to have a DNP to practice as a CNS. And most nurse practitioner programs are still, the majority are still at the master's level. So they have not declared that to be the final need either, because the research out there, although we push it like we've always pushed a BSN over an ADN, right? Mm-hmm. We still see more ADN programs than BSN. I mean, so we think in ideals, but it's not necessarily practical. And we need to get people to the bedside because that's where the care is needed with our nursing shortage and our APRN CNS shortage. So we don't want to hold people back. So just so you know, it can be at the master's level for the CNS, and then you can go on to your DNP if you'd like, although we do have some programs that are strictly DNP to get your CNS. And you can find all that out at our CNS program directory webpage at the NACNS website.
And we'll put a link to that in the description of this episode, so people who are interested can check that out. Because I have talked to people who are like, I love patient care, but I don't like that structure. I round on X number of patients. Yeah. And you're prescribing, putting in orders, and like to have this very viable option of very direct nursing care and consideration and elbow to elbow with nurses. I think that is a really great option for people who want to progress educationally, be more challenged and whatnot.
Yeah. The people who do it love it. CNSs are very happy people. And I'm going to give you a statistic. When the pandemic happened, right, and we don't even hardly want to talk about the pandemic, but we have to talk about the pandemic. For 2 years, there was one provider whose satisfaction levels went up over those 2 years. out of RN, LPN, nurse practitioner, nurse midwife, nurse anesthesiologist, it was the CNS. For 2 years, we were totally in our element. Mm-hmm. We were in the worst of situations. We needed change to happen fast. We needed evidence-based practice happening in real time at that moment. And CNS's work could not have been happier. I know. Call that weird. But we're in crisis every day. We know we are. We have a financial crisis in the healthcare system. We know that we have to be so nimble in everything we do with healthcare spending. That is right up the alley of the CNS. They just fit so well with the times we're in, and I would say the times we've been in with the pandemic. That CNSs are truly happy in their role because they spread their wings in a different way, and have this autonomy to just, where's the gaps? I'm going to fix it, and working with the chief nurse officers and the C-suite along the way.
So let's, like you mentioned, you worked on a medical surgical unit as
multiple
a CNS.
5 units. Yeah. So I covered 5.
You clock in for your day as in that role. Can you tell us very practically, what a normal day in that role looked like?
Yeah. So you check in with the nurses to you see what happened the night before. So you're very involved with the units and any issues that are happening, any patients that are not doing well that you need to go in and see right away with the nurse. Maybe a patient maybe had some mental status changes, maybe a patient fell, whatever's going on. So you're there to you're going to scope over the landscape and see where you need to be. And as we know, patients are complex all over the place, or maybe there's a difficult discharge, or maybe there's, just things that the nurse needs more support in. So in my role as a credentialed and privileged APRN, which happens a lot to CNSs, that you are privileged to write orders, I would actually see patients and be able to walk out of the room then and write the orders for that patient. If we needed a patient to be discharged that was complex, the physicians may ask me to discharge that patient, write the orders. So now I can see the patient, get the patient out the door, work with, and I did a lot of transitional care. So I knew the community resources. I would hook them up with the oxygen company that would come in, and do their thing with physical therapy, home care services, long-term care. So I would be that transitional APRN to make sure that when the patients left us, they were being well cared for, because we know social determinants of health are a bigger factor in outcomes than what we do for our patients. So that transitional care was extremely important for me to make sure that when patients were discharged, they weren't going to be readmitted. They were actually going to get the support and care they needed at home. So transitional care role, being able to prescribe, move patients through the system a lot faster, do procedures. So whenever a patient pulled their Dobhoff tube feeding out, their Dobhoff tube, I was trained to put them back in. So the physicians didn't have to come up from wherever they were and they would just call me and say, I got a call. Can you, take care of this Dobhoff tube? So a lot of things I'm telling you were billable procedures. So I was able to bill for those services as a CNS. And the other thing I would say I did a lot of was having crucial conversations with family members, another billable service.
Really?
Oh, yes. So what happened was the physicians would see me doing a lot of teaching, and they would tell me, we can bill for those services. So I would learn from them, because when I graduated in my program, CNSs weren't necessarily taught about coding and billing and all that like they are now, because we didn't have full practice authority back then. We got in Michigan, we got prescriptive authority in 2018. But before, but you can work in collaborative roles with physicians in most states anyway. And if they give you those privileges, those are delegated functions, you can do them. And you just re-sign your contract every year with an umbrella of physicians that you're working under. But those crucial conversations were really important. Those were for families, and I was at a level 1 trauma center.
Mhm.
So we had a lot of younger patients, severe traumas, brain injuries. They needed to be taken off the ventilator. And so a lot of conversations about terminal weaning or moving them into hospice care. Physicians were not comfortable having those conversations.
Yeah.
They
Yeah.
still aren't.
Yes.
So they would say, I tried to talk to patient and the family, the family. I don't think they really understood. Would you go and talk to them?
Mhm.
You get a lot of that. So as an APRN, clinical nurse specialist, and I would say the other APRN colleagues as well, those complex communications and those expert communication skills, you can see where you kind of stop as an RN and then you go to this different level of conversations and meetings with patients and families where you're the leader, you're the one running the meeting. Just explaining what hospice care is, when you have those hospice beds in a facility. And I can remember so many stories of the family just needing more support to understand, what does hospice care really mean? Why aren't they getting their medicines, or why aren't you turning them, or why aren't you, and you have to explain about end of life cares. Right. So it takes, I was in practice for about 5 years as a nurse when I knew I wanted to be a clinical nurse specialist. So I already had some experience. So I know for some of your audience, I think if you're in practice for a year or two, you start to know already. I think we have a different graduate now. I think they're higher level, honestly. And I think they can quickly pick up on the nursing skills to move into a program like a clinical nurse specialist within a year or two after graduating with their RN. I really do.
That was actually one of my questions was going to be, if I remember right, it was 1994 is when you started working as a CNS. Is that correct?
Yes.
So when you look back at you graduated first year on the job and then compare that to 2024, what are some of the biggest differences between back then and then now, in your day-to-day, what have been some of the biggest surprises in the evolution of the field and your practical day-to-day?
Staffing and the issues that nurses face were not as bad as they were. They're so much different and worse today than they were back then. I can remember back then, on day shift, you'd have 3 to 4 patients. And if they wanted to give you another patient, you were like, no, not happening. Now 7, 8, ICU, multiple patients used to be 1, or you threw a fit.
Yeah.
And so and I think the complexity of patients, the older patient, more comorbidities, it's more difficult to get patients out of the hospital now. That throughput, that is such a common term, from the minute they step in the door to when they're actually discharged. We're doing a very poor job on that because I think there's so many more comorbidities, staffing issues, the way we're delivering nursing care. Nurses are not always doing RN duties. They get stuck doing a lot of other duties too. So nursing needs work. And I think that the pandemic exposed a lot of weaknesses in nursing and what we're doing. So I'd say the staffing levels, the workforce issues are some of the worst. And I think because financially, healthcare systems are very strapped. They're very strapped on spending money and monitoring the dollar sign, that they have less leverage to hire more people. So they're looking to be very nimble, and I think for the clinical nurse specialist, any nurse that wants to advance, they better be able to articulate how they are going to impact the bottom line, their fiscal impact. That's not language we necessarily talked in, I think, years ago. It wasn't as crucial, and I feel like it is now. It just seems to be far more prevalent now.
Yeah, we talk about like being the CEO of your own license, where it's like, like
I
it's
love
almost
that.
like the business aspect that, as a nurse, we're not business, we're nurses.
Yep.
We want to take care of people, but you also have to have sort of a business mindset to not to be able to leverage your license and your expertise and advocate for yourself, to get those raises or get those roles that you are qualified for that you think you deserve or that kind of thing, which is
Yes.
definitely not something that I think if you're feel like born to be a nurse, like the business side and nurse side are just so different.
No, and you just nailed it. I mean, when I became a nurse and you just think of you want to help people. You just
Yes.
and yes, quality translates into profitability. It truly does, but it's almost like we all need some business classes in nursing school too,
Yeah.
because the landscape has changed that much that we everyone needs to get on board now with being more efficient. And that's why I've always loved the CNS role, because I did take business classes in my CNS program. I mean,
Hmm.
you come out just thinking that way about decreasing length of stay, fiscal outcomes. So that's the mindset of the CNS. So we've always kind of thought that way, but it really needs to trickle across the board.
Hmm.
So important.
It's so, and like being able to flesh out these different roles, like, because for people who want to progress and want to like do something new, like, you have obviously this role, a manager role, a nurse practitioner role, or an APRN in various capacities. Like, so I think it's really helpful to have, I had a nurse manager on recently. So it's really helpful to have these different professional options that people can really consider. Because I think the worst thing is when you go through the work of a degree and you get to the day to day and realize, "Oh, I don't like this." Like I've had nurse practitioners be like, I hate this. I went through all the school. It was
Yeah.
horrible getting a preceptorship and it was horrible
Yeah.
getting a job. I don't like my job. I'm working with a physician who's awful or,
Ugh,
you know,
yeah.
so it's how I think it's so empowering to be very clear about your goals and objectives when you commit to a degree.
Katie, another thing came to mind when you were just saying that. I went and talked to an undergraduate group of nursing students a few weeks back. And when I asked them, how do you feel about this profession that you've chosen? For the first time ever, because I've done this so many times, talked to younger nurses just getting their degree. There's always been enthusiasm. Like, I'm
Yeah.
so excited. I did this, I did that. This was the first time when we went around the room and people were worried. They were worried about the environment they're in, the staffing issues. They're feeling the vibes of what they're experiencing in their clinicals, and it was saddening to me because I can remember back. Now I graduated a long time ago from nursing school, 1989, but we were just rolling and we were
Yeah.
just so happy, and there were jobs everywhere and you were getting sign-on bonuses, and it was just such a happy time. And AIDS was really HIV AIDS that had just hit the scene. So we were dealing with that, but we were still a very satisfied group. We still loved being in nursing. And I feel now with the turnovers that we're seeing, and you mentioned the nurse practitioner, I think there was a turnover rate of like every 3 months. I mean, it is hard for everyone across the board. And I think you need to really explore who you are and figure out what role is best for you. And that's where I always think if people knew more about the CNS role, we would have triple the numbers that we have, because so too many people come to me and say, I didn't even know this role was out there. This is exactly what I want to do, but they didn't know. So,
How difficult is it? Like, you mentioned that other hospital that wants one in every unit. That
yeah.
sounds amazing and very
Yeah.
ambitious. Like run-of-the-mill hospital, how many CNSs are working there?
Well, that's the thing. See, as some facilities they don't have any CNSs at all. So he asked me in our talk, well, who would be the next best person that could kind of fill in if the CNS isn't there? And I said, well, I guess the nurse manager, because
Yeah.
they're on the, and he says, that's not happening
Because you
because
can't find
they're
nurse managers.
well, they're just so strapped, right? I mean, they have a whole different set of roles that they have to carry out every day. They can't be at the bedside now handling all these problems and meeting with patients and families and
Yeah.
upset doctors. And that's the CNS. I mean, we run to these problems, I mean, so he was like, well, that's not going to happen, and I said, but I can't think of another provider who has the training like the clinical nurse specialist to do what you're asking me. So I can't give you another provider.
It
So
sounds, so what I'm hearing is like there won't necessarily be opportunities at every single hospital, but there is a demand there
the
for the
demand is
hospitals that
there.
do have them.
And all your magnet facilities pretty much have them.
Okay. Oh,
So
that's a
that's
good
important
way
to
to
know.
know.
I
Okay.
mean, and your big hospitals like Cleveland Clinic, they're loaded with clinical
Hmm.
nurse specialists. I'm just throwing that name out there. Um, so they are in the facilities where they want magnet and they want that level of nurse quality outcomes, because it's very hard to get it if you don't have dedicated people like clinical nurse specialists who can focus on all those nurse sensitive indicators, that cross the board from patient to nurse.
Yeah. So from my
So,
understanding, people who are doing those jobs like quality outcomes and things, they're more like big picture data or just data reporting and gathering, not necessarily like solving that problem and
yeah,
on the unit and with the
yeah.
nurses.
And the CNS has to go between the front lines of care, the nurse, right to the C-suite.
Hmm.
So those other people aren't. So that's the connection. That's the APRN, CNS. You're meeting with the C-suite, so you're really connected with the needs of the system, and you're bringing it down to the front lines, and then you're advocating for the nurses and taking that to the C-suite too. So you have that support, that go between. It is so important. And when you hear of facilities who have them, I've been at conferences where they'll say, if you're lucky enough to have CNSs,
Yes.
blah, 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 because just what I'm telling you, it's such a needed role. For me as president of the organization, and to have given the kind of, it's all volunteer time on my own, in addition to my day job,
Hmm.
it is so worth it because it's just such an important role. And if more nurses hear about it, like through your program and the things we're doing at the national level, we'll be in good shape. We just need more CNSs.
I have two more questions for you. One is very practical. What is this? Is this like what's the schedule like? Is like the nurse practitioner is working probably those business hours. Is that the same thing, or is this more like shift work like the bedside nurse?
No, it's more business hours.
Okay.
Yeah, it's not like a 7 to 3, 3 to 11, 11 to 7. There are some CNSs that do work nights. They will come in and they cover overnights, because at nights that's when all the problems really happen, right? I mean, let's be
Yes.
honest, we've all worked night shift. So some CNSs enjoy that and work nights, but predominantly it's a Monday through Friday kind of business hours. Um, CNSs are moving across settings too. So if you're an orthopedic CNS, you may have a clinic day, right? You may shift over into the joint clinic
Oh,
for part of your
okay.
time. So the beauty of the clinical nurse specialist, and if you look at the CNS journal, my first two columns as president, actually it was the second and third column. It was in the June, May, let's see, it wasn't March, April, May, June. It was the summer issues. I gave my top 5 reasons to be a CNS, and then I gave my next type 5 reasons to be a CNS, but autonomy was in there because you come in and you create the role. I mean, but honestly, you get in and the role is created for you because you walk into these problems every day.
Yes. Yeah.
But I will say a CNS is working on 1 to 2 big ticket items every year that's going to result in cost savings in the millions.
Okay.
Okay. So we're talking, that's the business side. To validate your role and justify your role, you have to justify it through dashboards and scorecards of what you're doing. Okay. So, because a nurse practitioner just will see patients and bill for those patients,
Correct.
done, next day, same thing.
Yeah.
The CNS does not always know what they're going to be working on. If falls is the problem, if hospital-acquired infections is the problem, if there's inefficiencies in the perioperative area, the CNS can work on that maybe for the scope of the year to show outcomes of millions of dollars in savings.
So
Do you
that's
see? So you're
interesting.
tracking all that. You're a data person too, clinical data person.
Interesting. So you get a little bit of these different, like you have the enjoyment of like working with patients and with nurses to help actual clinical problems, like maybe I would maybe call it like smaller fires during the day, but then you have
Yes.
these long-term
Yes.
goals and
Yes.
initiatives to like overall help the system.
And justify you being there.
Yeah.
People don't always know all the fires you're putting out all during the day until you're gone. And then they're like, gosh, we didn't have this problem when we had a CNS, right?
Yes.
So you have to be savvy in the role, and we have to always be thinking about justifying our worth,
Mhm.
or you get eliminated.
Yeah.
And that can happen. I'm sorry, my dog's barking. Someone's at the front door.
It's okay. I have a dog too, and I'm like, gosh, I hope that
Barks
package
at the
doesn't
wrong
arrive.
moment. Ah,
Well, I have one last question for you. This has been
yeah.
so insightful. So, if you could sit across the table from the 1994 version of yourself embarking on this career
Yeah.
for the first time, what would you tell her?
Um, you are in for the best role in your life. There is no role like the clinical nurse specialist, because every day is going to be different. And unless you're the kind of person that just likes so much structure that it's just, to me, that's boredom. Um, every day is going to be different. And you have the ability not to change patient and families' lives one patient at a time, but through your efforts, you affect thousands of nurses who will go on to affect the lives of thousands and thousands of patients and families by how you work with the nurse, how you change the system. And of course, you're going to have those very special, tender moments with the patients and families that are in your specialty population that you love the most, of course. But I have never doubted being a nurse or ever wished I had done anything other than what I've done. But when I got my clinical nurse specialist, it was the cherry on the top.
Okay.
And I would say that you just have to know who you are and study each one of the roles. I would ask that of all your listeners. Study all the roles, because
Mhm.
I have a lot of people come back to my program and they messed up. They went the wrong route because everyone said, "Oh, do that. You should do that." Blah blah blah. So just really understand who you are and what difference you want to make. Think 5 to 10 years out, and then choose wisely, and come and talk to us at the National Association of Clinical Nurse Specialists. We will help you. We will help
Awesome.
you.
That's great to know that you've got like, if you're interested, there's a plethora of resources.
There are.
And just to know this option exists. And that actually, when you said that, it made me think of one more question that's a
Of
short
course.
question. Specialization,
Yeah.
like oncology or whatever. Do you
Yes.
get that specialization education in your CNS degree, or do you get that in on the job training?
Okay, so that's an excellent question. So when I admit a student to the program, and I'll put my program director hat on now of a CNS
Okay.
program. So when you have someone come to you, you ask them right away, what's your specialty? What's your passion? Most every nurse already has figured that out. I'm on oncology, I'm orthopedics, I'm peri-op, I'm emergency. But I'm going to give you the example of a student I had who was very specific in genetic counseling or genetic testing for cancer.
Oh,
Very specific. They sent her to be a clinical nurse specialist to improve the efficiencies in their clinic. and to function with that patient population with full practice authority, ordering, prescribing, but really improve the system. So she came in, and knowing that, she said, I need to be able to do skin biopsies so that when I get out, I can do them. So while I didn't know anything about that, I can't teach that. We made sure within the prescribed clinical hours that she was with experts so she could learn that and practice it over and over again. So we're really good about, this is the thing, you learn how to become a clinical nurse specialist kind of in a general way. We are very acute care and critical care focused, but I've never worked in critical care. And I run a CNS program. So, but I can have critical care people in the program because, you can translate that knowledge into whatever area you go into. But it's when you do your clinical hours, we want you in your specialty, advancing in that role, learning how to prescribe in that role, learning how to make medical diagnoses in that role, in that population that you are going to be a CNS of. So the answer is kind of yes and no in that you get the broader, but when you do your clinical hours, they're focused.
Okay.
And we make sure that when you leave, you have checked off on all the procedures you needed to learn. So for me, I was interested in women's health when I went through my CNS program. So I was teamed up with a nurse practitioner in the school health clinic so I could do pap smears, pelvics, all that over and over and over again as a CNS student. So when I graduated and went to the level 1 trauma center, every time a young gal came in and we thought she had pelvic inflammatory disease, guess who they asked to rule out pelvic inflammatory disease? Me, because then I would take the patient to the treatment room and talk them through it, do a pelvic exam to assess for cervical motion tenderness, learned it in my CNS program, so I could do those over and over again as a CNS. So you can see a CNS education will take your skills to the next level so you're ready to go when you graduate.
That's awesome. I love that there's this aspect where you can have very practical skills, because when you do some of these other roles, when you get into some leadership roles or general education roles, you're not doing those on you don't have that necessarily authority, or that's not within your role to perform like a pelvic or whatever, or put in a job off, someone else is doing it. So there's a lot of people who love their skills and they would love to practice them every day. And that's something they very much value. So that's a wonderful feature of like the CNS role.
Well, and then you got to think about when you get out and practice, and we all know this, you continue to learn. I remember spending one whole day at a chest x-ray conference because I needed to, when I met with a radiologist, like I put a Dopphoff tube in, which just wasn't just chest x-ray, it was radiology. When I went down and talked to the radiologist to find out if the tube was in the right place, or I had a patient, we needed to know right away if they thought they had TB, where we're seeing it up here in the apices. I needed to kind of understand when the radiologist started showing me the shadows on the x-ray, what that meant. So after I graduated, I went back and got a certification in just basically reading. So, we never quit learning because I didn't want to seem so dumb when I went to the radiology and I'm listening and I'm seeing she's talking about the shadows, and I'm like, I don't see a shadow. So, you after you get out and you see where you go in your practice, you start to see, I need a little bit more education. So you never stop learning. That's the beauty of it.
It is. I'm hearing that it's very versatile in your day-to-day, what you're doing, but then also your long-term trajectory too.
Yeah.
That's an awesome option for nursing. Like I always,
it's super cool.
I know, like nursing is such a great degree to have that baseline, and then there's so many different things that you can pick. So I'm very thankful that you took the time today to explain this option to newer nurses so that they know that this is out there.
I will come back anytime.
Yeah, maybe I'll get a whole bunch of questions and we'll just have to have you back.
Bring a panel on. I'll be ready. I can bring a panel of pediatrics, clinical nurse specialists, neonatal clinical nurse specialists. So, we cross the whole gamut.
Don't tempt me with a good time here. That would be wonderful.
Any oncology, I just met with a clinical nurse specialist not too long ago at Cleveland Clinic who started a whole service line on enteral feeding. It is her service line.
Wow.
She is at the top. So she will go and she is the expert on enteral feeding.
Wow. That is
As a
so
service
specific, but like so necessary.
Yeah. So needed. Yeah. Yeah.
So interesting. Oh,
Sky's the limit.
wow. Well, thank you so much for your time
welcome,
today.
Katie.
Thank you guys so much for listening. I hope you enjoyed the interview. I thought there were so many phenomenal pieces of advice and thoughts and interesting things about being a CNS that I, being a nurse for many years, was not aware of the intricacies because at the hospitals I've worked at, we didn't always have CNSs. So I wasn't very aware of what they did. So I think this is an incredible role, an incredible option. No shame to this NP role. That's a great role too. It's great to have different options out there for those of us who maybe don't want necessarily to have the same structure in a day that maybe a nurse anesthetist or a midwife or a nurse practitioner would have. So this is another wonderful option. I have links to the program directory that Dr. Saunders mentioned, as well as just the overall website to the National Association of Clinical Nurse Specialists linked below. If this is your first time listening to the podcast, welcome. Hi. What's up? Kati Kleber. Been a nurse for a while. I've worked in neurocritical care. I've worked cardiac med surg and some step down. And I am a nurse educator, and I create content and support for those of you who are entering the profession for the first time to really support you and kind of get into that nitty gritty of the things that maybe get lost in translation, or someone assumes that someone else told you that, but nobody ever actually told you. And all of those soft skills like assertiveness and how to handle challenging situations tactfully. So we have a website that is full of free resources, including this podcast, which has over 100 episodes. Almost all of them are evergreen, which means you can listen to them at any time and they're still applicable. We go over so many things that are necessary for that newer nurse to learn. And the first episode is what to expect on your nursing orientation. So if you're new, I highly recommend starting there. If you want to check out our blog, we have over 400 blog posts. They are organized by topic. So all you have to do is go to freshrn.com, and I have a little thing that says topics. And I want you to click there, and I'm going to have a drop-down menu, and it's going to have 9 different things that you can learn more about, from med-surg to ICU, neuro, cardiac, ortho, general new grad support, professional development for the experienced nurses, and maybe even like some jobs and interview information. All of that is there. I have tons of free content that is all separated out by different topic. And then I also have upgraded paid services that are all courses that are self-paced online courses that are specific to those topics that are listed on freshrn.com/blog. So I have a med surg crash course, a cardiac nurse crash course, a neuro nurse crash course, ICU, ortho, precepting, charge nurse, nursing basic skills, all those things so that you can learn at home when you're not face-to-face with your preceptor. You can kind of study up on the practical information that you need to know at the bedside. I know we have our nursing school textbooks and have our nursing school exams that we passed, but there's a huge difference between that textbook information and then what is realistically expected of you at the bedside, in the hospital, wanting to look smart and ask really good questions. So this is to empower you to be able to do that and ultimately expedite your orientation experience and just give better care, have a better experience as a new grad, and ultimately get to competency faster. So thanks for listening. Thanks for hanging out here. I appreciate you. The best way to stay updated is just to get on our email list. So I will drop a link to do that in the description of this episode, as well as where you can find our course directory and our learning hubs and all that free content we have. So thanks, nurses, and stay fresh.